So to begin with, we'll be talking about mandible, the intraoral approaches to the mandible. The whole idea of this lecture at the end of the session is you should know what are the structures we are talking in relation to the intraoral mandible specifically. Now, mandible is the lower jaw. It's a horseshoe-shaped bone which houses the teeth, and it's a main anchor for all the facial muscles which are attached there and the muscles of mastications that insert in. This topic that So I'm not going to specify this. This is all that we are going to cover at the end of these 15 minutes. And yeah. So basically we'll have an idea of the development of the mandible. The whole idea is we'll know what structures grow along with it so that we know what is around this mandible. So when we begin, there's this ossification center that develops around the Meckel's cartilage around 7th week, which we see in there, and that structure grows ventrally to form the body of the mandible, and then it grows posteriorly and superiorly to form the dorsal ramus of the mandible. We will know that in the midline at birth it is not fused and it's a fibrocartilage. So it's both a membranous and cartilaginous structure. Can anyone tell me what age the mandible fuses in the midline? Anybody? Anybody? Okay, we'll not waste time. It's within the first 1 year. The range is between 4 months to 1 year of age. So these are the structures that are derived from the mandibular arch. Every arch will give bone, vessel, muscle and nerve supply. So now coming to the growth and development of mandible, we'll be seeing the postnatal growth and also the age changes in here. The postnatal growth, as we understand by the Enno's V principle, this bone grows laterally, forwards and superiorly. So the main areas of ossification here or by the appositional bone, you see a superior growth because alveolus develops, you see the teeth coming in, then you see the inferior border, you also see growth at the chin and the posterior border of the ramus. Where it resolves is on the inside along the anterior ramal border, along the submental sulcus. These are places it resolves. Age changes, main things that we see is as alveolus develops, we see the change in the position of the mandibular nerve canal and the mental foramen. There's a change in the angulation where the ramus and the body joins. This becomes obtuse in the initial stage, becoming almost 100 degree, 110 degree. And then again with the loss of teeth, loss of the alveolar process, which begins again a obtuse angle. So parts of the mandible, superiorly we have the alveolus, which is encasing the teeth. The teeth and the alveolus have a junction called gomphosis, which is lined by the periodontal ligament. This is one of the gateways for the transmission of infections and for the transmission of tumors and various dental pathologies. The inferior part is the body of the mandible, which is a bicortical bone, has lot of trabecular bone. It's also a rich source of cancellous bone from the mental area. Then the junction of the body and the ramus forms the angle. Ramus is the vertical part. It has condyle and coronoid processes. This picture, the idea is to demonstrate that the muscles which attach onto the mandible cause ridges, elevations, depressions. It is because of the pull and push of the muscles we see appositional growth and resorption. You also see multiple foramina and small tiny pores. These are the periosteal vessels which are entering in and out of the mandible, other than the alveolar artery which also supplies it. So we see the attachments of the muscles of mastication and the facial expression. The idea is not to show these insertions. Keep in mind that this is the area where if you detach, for example, the mentalis, when we take it off during the genioplasty or harvesting of the bone, we need to do a two-layer closure. You need to attach the muscle back to the periosteum because it will prevent droopy chin or the witch chin appearance. That's the significance. The mandible on the lingual surface again is divided superiorly into the sublingual fossa, inferiorly into the submandibular fossa. You see that there is this medial pterygoid muscle insertion. Laterally we had seen that there is ramus mesenteric insertion. So pterygomesenteric sling here, it forms an important structure which causes growth there, and also we determine whether an angle fracture is favorable, unfavorable depending on the pull there because of the sling. One small important instruction, we see the external internal oblique ridge which are enclosing the retromolar area. This is also an important site from where infections and tumors can go towards the ITF, to the buccal space and the pterygomandibular space. These are the muscles attached. When you give an incision for doing a third molar surgery, you palpate the external oblique ridge, try going laterally, don't go medial to cause any vessel damage. One other structure intraorally we see, it's a triangular submucosal fold of structure. We call it pterygomandibular raphe. The raphe is nothing but a junction of two muscles. There's a small video depicting this. This is a video wherein we are trying to depict the pterygomandibular raphe, superiorly attaching from the medial pterygoid hamulus coming down to the mylohyoid line. Anteriorly the buccinator inserts into this. Posteriorly you have the superior pharyngeal constrictor which inserts, and to the inferior anterior border of the retromolar area we had seen in the previous picture. This is the structure that we pierce immediately after we go submucosally while we give the inferior alveolar injection. This is a superior view of the same thing. We are seeing the positions of the nerves, vessels and muscles here. This again is a point of transit from where infections can go into the superior pharyngeal space. It can come to the buccinator space, go to the mesenteric space, superiorly into the infratemporal space. Inferior alveolar now. We all know it passes through the mandible, divides into incisive and the mental branch. What is of significance here is understanding, again because of that lateral, anterior and superior growth of the mandible, you see this anterior looping of the inferior alveolar nerve at the eruption at its exit from the mental foramen. Now this is relevant when we are putting an implant or doing a pathology surgery there because you want to keep the nerve safe. Currently we are pretty safe. We have seen you can know whether it is mediolateral, superior, inferiorly, what's the extent. Also have an idea of the relationship of the IAN to the third molar tooth before you embark on a surgery for this. Now coming to the lingual now. What happens is after coming down from the cranial base, it is medial and lying submucosally along the third molar to the second molar area, and passing then more medially towards the midline, looping around the submandibular duct before it supplies branching into the floor of the mouth and the anterior tongue. Can anybody tell me what structure I am pointing here? The query is to what structure? What is hanging from the lingual nerve on the sublingual gland there, submandibular gland, deep part?
Ganglion. That's a ganglion.
Yeah, which one?
That is submandibular.
Yeah, supplies the secretomotor fibers there.
1 second.
Huh.
We have chocolates for the right answers, okay?
For the questions? Okay, this is a clear dissection of the lingual nerve, courtesy Dr. Siddharth. Okay, so we can see clearly there is this lingual nerve which is passing down towards the medial side into the tongue and floor of mouth. Another structure of relevance are facial artery. In its facial part, after looping around the submandibular gland, it comes onto the face. What's of relevance is when you do any incision in the intraoral site along the vestibule, around the first molar area, always bevel your blade towards the bone, never go onto the buccal soft tissue side.
4 minutes.
So, floor of the mouth, We know the structures here, the sublingual and the submandibular gland. Most important significance is of the duct and the lingual nerve which run in here. Floor of the mouth that we see, and the yellow structure I am trying to depict how the lingual nerve would course through, and the submandibular duct. Now this area which is lateral to the course of the nerve, which is the sublingual fossa area, that is a safe site for putting incision or taking a clavicular incision when we are to do a tori removal or an impacted tooth on the lingual side, or putting an incision for IND, or doing an incision for the submental intubation. So to conclude, these are things that we need. Please keep in mind that know your anatomy well, plan anything, unless of course if it's an emergency. Always review your plan wherever essential. Do not regret, because you're trying to do your best, and always learn from your failure. And for every patient, you follow sterilization protocol. Think everybody is HIV positive, hepatitis B positive, because you give the same treatment to everyone. We need sterilization for everybody. Keep it clear. That's all from me.
Okay. Thank you so much, Radha. We'll take questions towards the end, okay?